Welcome everybody, it's just on 12:30, so we shall get started. My name is Nick Holding, I'm an improvement manager with the Emergency Care Improvement Support Team, so that's ECIST by another name. I'm really pleased to welcome the team from Walsall Healthcare to talk about the discharge lounge. So just to let you know that we are recording this session, and so I'll be sharing that link back in this chat, and we'll put that out on through social media and other routes as well. Over the next few days. We've got the chat open as well, so please put any questions you want in the chat if you need to. We will have a little section at the end for Q&A as well if you want to pick the brains of Rach and Nicky a bit later on. So I first met the team back in October when I went over to Walsall to record a podcast. We've got a podcast series, and I'd heard about the Discharge Lounge that was doing some really great work in the organisation. I think when I went over and spoke to them with Ned Hobbs, who's the coup, I think what I was really impressed by was the total focus on the patient. This wasn't just a Cinderella service stuck in a cupboard somewhere or a little bit of a space that they'd found. This was the commitment to an actual a department and a team, a substantive team, which the team will talk about, which was seen as an integral part of patient flow and the patient's journey through the trust. And I think it was that commitment that really came across really strongly. And the team, the guys here, will describe their journey in terms of where they came from, which I think a lot of people will recognise, but more importantly, where they are now and what their current discharge lounge looks like and what the future holds for that. I think above all as well, what the Discharge Lounge I was impressed by was the commitment from the executive team and senior leaders to establish this as part of the organisation and protect it, and definitely not bet into it as a space for capacity. But I'm not going to sort of steal any more thunder from Rachel and Nicky. This is their story, and I just wanted to give this opportunity after a request from one of our WhatsApp groups to set this up, and I think the response has been phenomenal. So hopefully this will be really helpful for people, and then any questions you can pick up later on. So I don't know who's going first, but over to you, Rachel and Nicky.
Thank you very much. I'm going to go first. So just quick introductions. As you, obviously, I'm Nicky. I'm the lead nurse for capacity and patient flow, and this is Rachel, who's the band 7 actually on the Discharge Lounge. Just a quick update for people who aren't aware. Walsall, we are based in the Black Country. We are your average little general hospital, I suppose. We have roughly around 500 beds. 380 of them are medicine. We have obviously our own A&E department, and we roughly have around 280 to 300 attendees a day. That's just to give you a rough idea really of the size of the hospital that we are, as I'm fully aware that everywhere is so different. So I'll start off with our discharge lounge, and I will say this isn't an actual picture of the lounge as it used to be, but it's a very similar space to what we started out with. So we've probably had a discharge lounge here for around 10 or 12 years, if I'm honest. But I wouldn't say it was a recognised adversary to patient flow at all. So it was an area that, as I say, similar sort of area to this. It was moved around ever such a lot. Every couple of weeks it would move. We was in an office space, sort of like the one you can see on screen. We'd be in a bay at the end of a ward, and then every time capacity got tight and they needed the bed space, it would be moved again, and that would continue and continue. There was no substantive staff whatsoever for this discharge lounge that we had at the time. Ran purely on agency and bank. No definitive band 7, so the band 7 would be somebody from a ward who would be asked to look after it, babysit it for a couple of months, and then it would be passed to the next. To be honest with you, nobody knew when it was open, when it was closed. It was really hit and miss. So that's where we sort of started from, and through that discharge lounge we would probably take around 4 or 5 patients a day. That would be about the limit that we took. Yeah. So Our journey really started in April of 2019. I had been a member of the site team for the previous 10 years prior to that, and actually got then the opportunity to become the lead nurse for capacity and patient flow. And that's when we really started looking at what Discharge Lounge could provide to us. So the first thing I asked was that Discharge Lounge could actually be aligned to the site team, and I would take over the responsibility for the Discharge Lounge at the same time. And the exec team that we had were really supportive of that. Just outlined the fact, that we really thought that it could support patient flow in a lot of ways. The collaborative working that we could do together made sense, that if there was a line together, we would get a better focus, and they absolutely accepted that. So that's what we did. I then sat down and sort of came up with a plan. The first thing for me was to appoint a senior leader. We wanted a person who was specifically in charge of the Discharge Lounge. I wanted somebody who understood patient flow, and luckily for me, Rachel fit that. Rachel was previously a sister on the AMU here, the acute medical unit, so obviously had a good understanding of patient flow, but she was also somebody who I knew made sure that patient care was a priority, and that's what we wanted. We wanted something to support patient flow, but also ensure that the patients received whatever care they needed while they were still there. So probably July time, I think it was, when Rachel was first appointed into post. Discharge Lounge remained open throughout this time, but in the guise as it was previously, with this bank and agency staff, and very hit and miss. So we sat down then and created a workforce plan. And what we wanted was a designated specific Discharge Lounge. We decided what it was that we wanted from it, what we wanted our staff to be able to provide. We wanted to understand what support it could give, and also to make sure that patients were at the centre of it. So that's really what we started off with. And within that workforce plan, we did look at what benefits we thought we could ensure our staff could do that would support that. So we looked at simple things like, when we was looking at the workforce plan, we looked at the number of healthcare support workers that we was included, and we came up with a decision that what we wanted was, we wanted enough of those to be able to go out and fetch our patients. We didn't want to rely on portering. So that's the sort of thing that we worked for, really. We wanted to invest in staff who were invested in the vision that we had, really. We also wanted to make sure that we had enough qualified staff on shift so that we could look at the type of patients that we was fetching. So obviously the majority of patients are medically fit and are waiting to go home, but there are times where there are patients that are waiting last dose of, I don't know, IV fluids, antibiotics. They were awaiting a blood result that isn't going to change the discharge, but still needs to be identified. The results need to be identified to doctors. So we wanted to make sure that we got enough trained staff as well that would be able to incorporate all of that. So that's the sort of thing we looked at with the workforce plan. The next thing then was for us to be found a permanent home. As I say, Discharge Lounges previous literally moved. You could come in on a Monday and you'd be moving again on the Monday afternoon. So it was really, really important to us. We had the perfect home, a permanent home that we could then create and into the environment that we wanted for our patients. And I have to say, the exec team here were again really, really supportive of that. And that's why I've put on that bottom point there. We did receive full support. We shared our vision with them. They accepted it. They allowed us the time to develop what it is that we wanted to develop, because this did not happen overnight. This is a process that we're into our third year now. So that's just to make sure that people recognise that, really, and that the execs bought into that, and they allowed us the time to develop into what it was that we wanted to develop in. And as Nick has said, absolutely full assurance, we have never ever put an inpatient overnight into our Discharge Lounge, and the assurance is that we will never will, and that's really, really important for us. Just a quick point then, I'm not going to labour it, but just a quick things on a couple of things that we actually brought in. Myself and Rachel sat down then, and we almost decided that Discharge Lounge needed to be reborn. We needed to recreate the picture that we'd got and get rid of the old story, really. So we set out and we promoted the new discharge lounge. That involved posters, it involved going out to wards. We attended team meetings on wards, and it was all with the mantra of all patients go home via the lounge unless. And that list then we created, and it's quite small really. So obviously end of life patients will not come to the discharge lounge. We're not disturbing those patients. They can stay exactly where they are until the time is that they are discharged to their destination. We also disclude some, but not all, dementia patients. So what will happen is the team from here will go up and do an assessment on an individual patient. If it is felt that the move would be detrimental to the patient, i.e. that it would confuse them further, then we do not move the patient. If it's felt that the patient can move, we have a conversation with the ward staff who have been looking after the patient, then the patients come down. So we literally just pushed the message out to the wards and tried to make the discharge lounge part of the patient's normal journey. We tried to normalise it, that this is where the patients come. Another thing that we looked at within our site team, we actually book all of our own ambulance discharges. We have an outside contract and the company then provide the ambulances, but we've got access to their system so that we actually go on and we book our own ambulances. And the site team will challenge every patient when they're booking an ambulance, is this being booked from discharge lounge? And if they say that the patient can't go, we will professionally challenge, why can't the patient go? So again, it's still reinforcing the same message that our expectation is that all patients go through the lounge. We have various site meetings throughout the day within the site team, and what we do, we come up with a definitive list of definite discharges and potential discharges ready for that meeting. So what we do then, we share those names with the discharge lounge. They then will chase up the wards individually separate to us. So it releases us to carry on flow, but they're coordinating the discharges. And we also, if we get any further names throughout the day, we'll share those in real time. So there's a lot of communication going on between the site team and the discharge lounge team all the time. And the bottom point there, it is slightly out of order, but the bottom point there, the shared drive, that's something we've developed to support that. So there is a shared drive now between the two departments. We've got it in the ops centre on a massive screen. And what that allows us to do is discharge lounge update it. They'll put in all of the details that they need, so we've got an accurate record of patients, but it allows us in the site team to see when the patient actually physically arrives in the lounge. So that gives us the notification really that there's a bed available in real time. We then share that with AMU. Going back slightly then, identifying golden patients, we try to create a thing about having golden patients. So our golden patients are the patients that we can get to the discharge lounge by 9 o'clock the next day. These typically will be patients that are patients that have got confirmed packages of care, that are confirmed discharges to nursing homes, that sort of, we have a list sent out from our integrated discharge team by around 4 o'clock of the afternoon. We share that list with Discharge Lounge, and Discharge Lounge actually visit and talk to each of the wards that have got a discharge throughout that evening in preparation for the patient being ready the next morning. So it's not like we just ring up at 7 o'clock and say, where's your patient? We send us your patient. The work is done in the background. The picture that you can see on the screen is actually a bed hanger that we introduced. And the wards use these to identify the patients for the night staff, just letting them know that this patient will be going to the lounge the next morning, and it gives instructions on what's expected to make sure that the patient's ready to go the following morning. We don't want it to be a shock to the patient that at 7 o'clock they're moving. Obviously, that is going to upset some people. We absolutely understand that. Our idea is that if it's planned and people know it is going to happen, it's less of a shock, and it's less of an issue for them to move. They come down, they have breakfast in the lounge, and that's how we say it to them. Similar thing with identifying next day discharges. We liaise with the wards every evening in the site office. Any definite discharges we get, we pass the name straight onto discharge lounge, and a similar process from what I've just spoke about works with them. So none of it is a shock the next day for the patient. I put a slide on in pharmacy just to highlight, really. I think everybody would probably agree. What we found is the biggest delay we have to discharges is your electronic discharge summary, our discharge letter, our EDS is what we call it. And then the TTOs, the medication that the patients are taking home. They are probably our biggest blocker to getting discharges earlier in the day. So we've done a bit of work around these issues, really. We have had recently, we are trying to make it permanent, a specific EDS doctor, a discharge letter doctor. So this is a key contact that we can go to when there are any delays with the discharge letters being done. We do try and work to that patients going to the lounge have already had the discharge letter done. However, we will veer away from that if we are in terms of need for capacity. It's about the balance of risk, and then discharge lounge will obviously pick up any discharge letters are outstanding and liaise direct with this doctor that's been identified. We've also done a lot of work with pharmacy regarding the take-home medication. So we've set up the Mediwell now in the discharge lounge. So we are able to dispense some medications direct from the lounge rather than having to wait for pharmacy to dispense. Any patients that are in the discharge lounge, their take-home medication is prioritised by pharmacy. We have an identified pharmacy lead worker, so we have a definitive point of contact every day. They have a dedicated bleep, so that bleep is just for that pharmacy worker. So obviously they understand what our need is going to be. And we've also limited down the amount of time things can take by, I mentioned earlier about CSWs fetching and taking patients. We also used the staff to be able to fetch charts, fetch medication if it is going to cause any delays. I'll pass over to Rach now. The next couple of slides are just about patient experience. It is extremely important to us that we do the patient experience side as well as the patient flow side. So I thought Rach will be the best one to talk through. So she'll just talk through some of the processes and some of the benefits really that patients get from coming through our lounge.
Right, thank you, Nick. So as Nicky has said, obviously it is about patient flow and capacity, but the patient experience journey is just as important. So that was what I wanted to get the ethos of the lounge with the staff that we built up. So we provide food parcels for patients. So these are donated food parcels working with outside agencies and voluntary services, and they bring us food parcels for patients that have been in hospital, haven't had time or got anybody to go out to do the necessities. These are food parcels that are provided, and then we also provide like a picnic style lunch for them to take for when they get home, so they have got something to eat when they get home. There's also comfort packs, so these are like toiletry packs. If patients haven't been in hospital that long and they haven't got toiletries with them, we've got all these packs that we give them. It's just that sense of, oh, people actually care, and that makes a massive difference. My biggest bugbear when we first started was patients coming down in theatre gowns, hospital nighties, just sat in the area. So I came up with a clothes bank. So this is all donated, clean clothes. Some are even brand new, like you get from charity shops. And we actually, with the patient's consent, get these patients dressed. And yes, it is to maintain their privacy and dignity on discharge. However, you'll see if you get a patient dressed, they're that one step closer to home. Their whole mindset of, oh, I'm going home is better. They pick themselves up. They're more ready to go home when they are ready to leave the discharge lounge. So we also did personal touches. So at the time where you've got all these patients in discharge lounge, I don't know about your trust, we used to have plastic patient property bags, white bags everywhere. You didn't know whose were whose. So we came up with environmentally friendly bags with our logo on. where we could write names on, so patient property and food parcels, we put in those, you know, that extra special touch, you actually do care. We work closely with patient relations team and experience to see what their expectations were, what complaints they'd had previously, so you can build on that so you know which way to go. We're quite lucky where we are located now. It is on the ground floor of the trust, and just down the corridor, it's where all the PTS ambulances pick the patients up. So that's our designated pickup point, not just for ambulance crews, but for relatives, taxis, Red Cross, anything. It's literally just down from the discharge lounge. We also work closely with Walsall together to link the acute trust to the community. So you might have a patient in the lounge that you think, yes, they don't need an acute hospital setting. However, they just need that extra little support in the community. So we link in with our hubs for the areas of Walsall. We refer to the front door team, so they will pick them up, put them in touch with the locality of like the specialist nurses, the district nurses, rapid response. So the patient can still go home, but they're still being followed up in the community. So from our point of view, it's to try and stop that bounce back of the patient back into the acute setting because they've just been discharged and they've got no contact of any medical profession. And the patients really do feel that at the point of discharge, they're not just left, especially with your elderly patients. So this is the environment. So when I first started, I went round quite a few discharge lounges, and to me it was like you were sat in a waiting room, you were sat waiting for a buzz. It was very regimental, seats in lines or in a circle. So what I looked at, the area that we got, make it as homely as possible. So I linked in with our charitable funds and they gave us some money, and we got nice recliners, made it more of a living sort of area. So the patients come and they sit round a dining table. So social interaction, getting that patient in the right mindset of going home. We've got drinks facilities, snack facilities visible for the patient. So we've got a patient fridge, which you can see all the cold drinks, snacks. There's hot drinks facilities. So if there are patients that can make themselves drinks, they can do that. Obviously, we do the drinks that patients can't. But it was that sort of, some patients, I don't mean too frightened to ask, but if they visually see it, they're more reluctant to eat and drink. We also provide a picnic style lunch, so they'll have sandwiches, little bits that you don't necessarily have while you're in home, the pork pies, the sausage rolls, the crisps, and we also cater for every dietary requirement. So, or if patients want hot meals, just because they're in the lounge, it doesn't stop them from having those. We've also got our own supply and stock of wheelchairs, and my staff guard them with their lives, so that we can fetch our own patients, we can take our own patients out to the designated drop-off to relatives or third-party agencies. It's just, what would you want if you sat waiting for your medication? What would you want? And that's the sort of vision I had. We've got a comfy sofa. The other thing that was highlighted, so where we're based, signal on mobile phones isn't that good. So relatives couldn't speak to patients. Patients were getting frustrated. So I invested in a portable direct line, and it's only used for patients and relatives so that they can still communicate with their relatives. They can update them themselves. The relatives ring us on this phone when they're ready to be collected. We take them out. So it's just trying to bring patient flow together, but also patient experience. And like I say, as you can see in the slide, there's also facilities, reading, games, CDs, radios. We have a daily newspapers. We go and fetch daily newspapers for the patients waiting, sitting for their medication or ambulances.
Right, these are just some charts really, just to show you the journey that we have actually been on. As you can see, they start back in November of 2020. And this is Walsall. Walsall love these charts. Oh, absolutely adore them. So we have got these charts to show everything. But this is specifically the number of patients that pass through the lounge. Like I say, it is over a period of time, and that's what I want to get across really to everybody. This is not a 5-minute job. If you decide that you want to invest into your discharge lounge, you've got to be looking at the longer process to make it work. But as you can see, from the 29th of November in 2020 up until December just gone, there's a clear picture there of going through. Like I said right at the beginning, the old discharge lounge, we would average 4 or 5 patients a day from there. Our average now is between 35 and 40 patients a day. And that is every day. That is, so we've extended our hours now. We did a business case over the winter period of last year, and have extended our hours due as we found that it was what was needed. We are now open from 7 in the morning till 10 o'clock at night, 5 days a week, and we do a 12-hour service of a weekend as well. And that just shows really how well it has took off. So, thank you. Ambulance handovers within 30 minutes of arrival. This is obviously for our ED department, but I just wanted to explain really our ethos, the way that we look at this. So from our recognition, a patient going to the discharge lounge will actually help 5 other patients. So you've got the patient going to the lounge, they're moving closer to their discharge destination, they're getting ready to go home, so we're supporting them in the best way that we can. You've then got, because they've left an empty bed on a ward area, you've got a patient on our acute medical unit ready to go into that bed. So that patient is benefiting because they are now going to receive the specialist care that they need to receive while they're in hospital. Once the patient's gone from AMU, there's obviously a bed there, the patient from A&E can come into that bed. We're releasing up a cubicle, which will allow the A&E flow to continue. Once the cubicle is free, one of our ambulances, and we all know how difficult ambulance offloads are at the moment, one of our ambulances will be able to offload a patient. That in turn is releasing the crew to go out and pick up Mrs. Smith, who unfortunately has been lying on the floor for the last 8 hours. And we know, unfortunately, this is how it is at the minute. So that's the message we try and spread and send out to the wards when we're talking to them. We want them to understand them sending their patient to discharge lounge is having an impact on so many other patients. And it is absolutely recognised within the organisation that how well our ED department are doing at offloading these ambulances. Our discharge lounge is having a massive effect on it, is supporting us to be able to do this. They're not too standalone. We are very much in this organisation, a crowded ED is everybody's department, and that includes discharge lounge. So discharge lounge will do everything they can do to support A&E being less crowded. And this is the one that we're working on, I suppose, really. Obviously, you can see that there's some improvement. There's definitely some more consistency. So this is looking at trying to get patients into the discharge lounge earlier in the morning. We all know we're coming in of a morning, our ED departments are full. There are a lot of patients who've been waiting a long time for an inpatient bed. And it's about decreasing the risk in ED as safely but as quickly as we can of a morning. So we're looking to create some consistency really about the number of discharges we can get down to the discharge lounge. Like I said previously, we've got a number of processes in place now where we are identifying patients the day before. We're working with the wards to make sure that the patients can move to the lounge first thing the next morning, but it needs to be done safely. So we're doing a lot of work around that at the minute, but we are starting to see now some consistency really about trying to get the number of patients out earlier in the morning. So that slide was just to throw that in and just to make the point really that we haven't finished. We are nowhere near the finished article. We have a lot of work still to do, but I just think it's nice sometimes to be able to share some of your successes and support others wherever we can.
And then can I just add, from our point of view, the massive thing is to invest in these staff that are permanent now in the discharge lounge. CSWs, upskill them, get them doing bloods as well as obviously the nurses. They're all links, the staff in discharge lounge now, for things like dementia support, falls prevention. So everything that the ward bases do to improve patient care and patient safety is filtered through to the discharge lounge. And as well, recently we've just got a CSW that's now been accepted to do a TNA. So just because they're working in the discharge lounge, they are very, very important members of the team. And if you're given the skills and achievements that they can get, they'll do anything to improve the service. And it's just everyone now is upskilled, ECGs, bloods, everybody that comes through, all the things that acute nurses or CSWs do on the wards, they now do in discharge lounge.
And that's it. Thank you very much. Nick, I'll hand back to you.
Thank you, Rachel, Nicky. That was so interesting. Brilliant presentation. Thank you for pulling that together for us. Breathe. You can relax now. You're almost done. We have got so many questions, not unsurprising, and we'll try and get through them as many as possible. But what I will say is that if we don't get around to your question, what I'll do is I'll ask Nicky and Rachel to keep an eye on the chat afterwards and maybe just respond to those questions. That we don't get around to. So we have plenty in the chat, but just just to wrap up a few, the slides will be made available last. And so Rachel and Nicky, if you wouldn't mind sharing the slides with me, I can then share them around if you don't mind.
Absolutely.
And there's a couple of requests in the chat as well for a copy of the bed hanger, which seems to be popular.
Yeah, no problem.
Something like that we can share with people. That'd be. So I think there's a lot of questions around that. So if you want to stop sharing your screen, so we can people can jump up.
Bear with us.
We're working.
While you're doing that, Lucy, I'm going to just throw to you. I'm sure you've tried to scribble down all the questions that are available in the chat. We'll go to those first, and then we'll go to any hands up as well that are currently there. So Lucy, over to you first.
Thank you. So unsurprisingly, loads of questions, loads of interest, and actually lots of, I just wanted feedback, lots of chat about how innovative the work you're doing around patient experience and environment, some of the ideas you've thought of, and how important it is for patients and families' experience. So loads of questions. I'm going to start from the top. I haven't captured all of them just because it's coming in thick and fast. So if we don't manage to cover everything, I can keep a note. I can copy and paste the chats, and I can follow up with you, Rachel and Nicky.
Anytime, that's fine.
So first question: Do you have an ambulance or PTS member of staff in the room in the discharge lounge?
No, so we haven't. So we would like to look at having a dedicated ambulance purely for discharge lounge, and that is something that we're starting to put a plan together. Obviously, we do have our own PTS contract, and I say we're lucky in one sense. The operation centre staff here have a big part in that, so we are able to prioritise discharge lounge patients as much as we need to. But as to actually having staff or its own designated ambulance, no, we haven't. But it is definitely something we would be looking in the future.
That's our next.
Yeah, we want our own ambulance next.
So a question from David Rassan, and I think you sort of partially responded to this around your discharge letter doctor, but he's asked, do you have a doctor in the discharge lounge, and are TTOs and discharge letters completed in the ward?
So do you want me to answer that one?
Go on, carry on.
So no, we don't have no medical cover at all in the discharge lounge, no doctors. So like Nicky said earlier, with patients that come to the discharge lounge in the ideal world will have their discharge summary completed by a doctor. With regards to pharmacy, everything gets sorted out down here. if there are pressures to, obviously when you first come on in the morning and there's capacity issues and flow, if it is safe to do so, the patient is brought down without a discharge summary completed, and then discharge lounge staff will then chase for that summary to get done. If at any point we struggle to get it done, we then liaise back up to the op centre, who then escalates it, and then we have had doctors come down to complete those EDSs that we're struggling to get done.
Thank you. And just a follow-up question for me, actually. I presume that taking a patient without the discharge letter being completed has required a bit of engagement and changing culture from the ward staff.
100%.
Yeah, definitely.
And as well, having an EDS done is also a culture shock sometimes, because when we first took over, it was like anything goes, put it bluntly. So it was getting the safety aspect in it. And that obviously if these patients are coming down without discharge summaries, that obviously we're engaging with the staff so that we can get as much information about that patient as we know, so that it is safe when the patients come down here.
We didn't mention, actually, we do have a transfer form that the ward have to complete for when the patients come down, so that we have got that continuity and that knowledge of the patient to support the safety.
Excellent if you were happy to share that transfer. If you were happy to do that. So next question from Patrick Farrell. How does the lounge fit into your full capacity protocol if you use one times escalation?
In terms of?
In times of escalation. So do you use a full capacity protocol, and if so, does a discharge lounge have a part to play in that protocol?
So obviously, we do have a full hospital capacity protocol. To be honest, discharge lounge functions the way it functions every day anyway. So obviously in times of dire needs, I suppose the only thing is, like we said, we'll bring patients down without the EDS being done. But everything else we do every day anyway.
Normalised,
what we do is normal. So in theory, we don't have to increase anything. The only thing I would say is, obviously, as I say, the work is done in times of need, of when the extra support is given to the wards to discharge the patients. The actual process then of coming down to discharge down, and never, ever, ever, as I've said, is the area used for inpatients. It doesn't matter how crowded we are, it is never, ever used for inpatient bedded overnight.
Thank you. That's really helpful.
Lucy?
Yeah.
Lucy, could I just jump into the people who got their hands up as well, because I'm conscious they've been in there as well. So we've got Susanna first. Do you want to jump in, Susanna?
Hello, yes, thank you. I'm the sister of the discharge suite at the Norfolk and Norwich Hospital, and thanks for sharing all your insights and learning. I just wanted to ask if you could say one thing that you identified that got buy-in from the wards and from your trust to invest in you and send the patients down, what would it be?
For me, it would be, Rach may disagree with me, but for me, it would be, because we have got the site team and the discharge lounge team linked up, we're sending the same message. So to me, it's about repeating that message, repeat until it becomes normal. So every patient comes down to the discharge lounge and less. And to me, it's about the ward staff hear it that many times, it becomes normal to them. I suppose that's, for me, what I would say is the best thing.
And from my point of view, patient experience side, that if these patients don't come through the discharge lounge, they're missing out on so many benefits.
Yeah.
Of like the befriender service that we offer, the use of Red Cross, the food parcels, the environment. That's the side that they're missing out, because when we first started, we did have the patients that have been through the trust quite regularly, and they say, "Oh, I'm not going there. It's a cupboard." The patients used to say it.
You're going to the cupboard.
We're not going to the cupboard to sit there for hours, which it was. So what we try and do is get the staff to come and see what it's like, so that they can filter the information back to the patients that think it's still a cupboard.
It's about normalising the discharge lounge as part of the patient's journey. The expectation is the patient will use the discharge lounge as the final part of their journey in the hospital.
Okay, that's lovely. Thank you very much.
Thank you.
Thanks. Go to Jane Tordoff.
Hi girls.
Hiya.
I'll put my camera on so you can see me. I'm Jane Tordoff. I'm one of the matrons at Mid Cheshire Hospital. I had a 3-line whip last July with 12 hours to open a discharge lounge and get it up and running. So been really pleased to hear your experience. Quite heartened that we are and have managed to achieve quite a lot of what you're already doing, although there's some really good pointers that we can take away. What is your capacity in the discharge lounge?
So I would say we're probably maximum around 15 to 17 patients at a time. But
Is
what
that
I would say,
beds or chairs?
yeah.
Or...
So we've got Oh, you explain it better than me.
So I've got a separate bedded area that's part of the discharge lounge, which has 4 beds in it.
Yeah.
So that's designated for bedded patients. Then I've got 2 split areas, which will take about 15 to 17 patients, and a mixture of sofas, dining tables, recliners. And then I have a bedded side room, which fits a bed in. The other side room, we use more of like an assessment area or a barrier room. So if you've got patients that can sit but need a side room because of infection control, they go in there. Or if we have to do assessment things or IVs or anything, we facilitate that in the assessment area.
But to be fair, what we find is it's obviously like a continual in and out.
Yeah.
So you know, if there is a time that we ring up and Rachel say we can't take any more patients, we're full, within 5 or 10 minutes there's another one already left.
Yeah,
so it's a
same.
continual. Yeah, so I would say on average we're taking between 35 and 40 patients a day at the minute.
We're struggling. One of our we're doing very well actually, but we only have space for 10 patients. I will take more, but typically it's quite a small area. We don't have any side rooms or anything, but we are a bit like, I'm heartened by what you're saying about the buy-in, and it's just keep going, because it does feel like you're forever saying the same thing.
Yeah, definitely.
My other question for you is around, we don't really take anybody that's awaiting any investigations unless we know they're definitely going, because obviously, so how do you manage that? Because some of yours that are potentially waiting for blood results and things, if you're doing bloods on them, what happens if they don't, you know, continue to be a successful discharge?
So with regard to the bloods, so it's more like the acute medical unit, like areas like that, if patients have been in like a short time, so they'll come down and say if they want repeat bloods or a special blood to be reviewed in clinic or to be reviewed by the GP.
We normally know the patients are going.
That sort of patient.
You know what I mean? We do get the definite going home. We don't take a chance, if you like.
And then also with you, like, you know, like if you've got a patient that's on a last dose of antibiotics that's at tea time, so we will have their discharge summary done, their drug chart brought down, and the medication to give it. Or if a patient's got a few hours left on a bag of fluid that they just want to finish off, but their discharge process has already started.
Can I ask one very last question? And I know a few people have asked that, but your staffing, how do you staff it?
So there's me that's here Monday to Friday every day. When we did the business case, we fought to get band 6s, so I currently have 3 band 6s in post. It was just sort of like that more seniority, and the fact that, you know, these patients, even though they're fit for discharge, they can go unwell as well, so it's having that senior support. Then
how many HCAs do you have
on a shift? So we have 3 on in the morning, and they normally do till 5 o'clock, 7 till 5, and then we have a lap over a late that's 12 till 10. So our busiest period, we've still got a mixture of early and late staff on.
We purposely did quite a big overlap, to be honest with you. I know, like when ward staff do like earlys and lates, there's quite a short, perhaps an hour's overlap or something. We've made that overlap as big as we could, because we have found that's the busiest time for discharges. After lunch.
In your busiest period then in the afternoon, how many staff have you got at any one time, including yourself, Rachel?
So in between, sort of like, say if the earlies and the lates are on, so the nurses don't come on till 2. So in the morning there's 2 trained nurses and myself till 2 o'clock. Till 3 o'clock, sorry. Then there's an hour overlap with the late nurses that are coming on, because they come on and do a 2 till 10, and then CSWs, there are 5 in the sort of overlap.
Okay.
3 from the morning and 2 for late, because you will get it, like if people do come onto the department and they'll say, oh, look at all your staff, but if you think you have people ring up and there's 2 beds to fetch and a chair.
Oh yeah, I know. Yeah, I'm with you. I'm just intrigued.
Changing the mindset as well of areas, isn't it? Because like they just say, oh, you've got loads of staff, but then 2 minutes after you've gone to fetch 2 beds and a chair, so you've literally, your staffing's out and about. And like I say, they literally do all the running, catching, fetching. We don't rely on anybody.
That's what we built into the business case, do you know what I mean? The fact that we wouldn't have to rely on pharmacy to deliver medication. We wouldn't have to wait for porters to deliver patients. We wouldn't have to rely on porters to take patients out to meet relatives. The staff in here do all of that running around themselves. And for us, that prevents any delays.
Yeah,
thanks, guys.
That's what we do. Thanks very much.
Thanks for asking that question, Jane, because there have been a lot of people asking that question in the chat as well. So that's answered a lot of people's questions. But I think what you're saying is that it's you decided the service you want to provide and you're staffing it appropriately. So it's not like you're awash with loads of staff. They are delivering the service that you want them to deliver.
Yeah.
Okay, so I'm going to go to Pam, and then I'm going to go back to Lucy, and then come back to Teresa afterwards. Pam.
Hi, thank you. Yeah, I'm Pam Duro. I am the operations manager for the Discharge Lounge and Acute Medicine over at Sherwood Forest Hospital. So Jane's kindly asked one of the questions that I had got, so thank you, Jane. But the other one is, so you say that you're taking 30 to 40 patients, which is amazing. Can I ask, does that include ED patients? Do you take ED patients? Fab. Yeah. And what is that as a percentage of your discharges? Do you know that? I'm just sort of trying to collaborate it. We take about 20 to 30% of our discharges over here. So it's just a different way of seeing it. I don't know if you know that.
I haven't got that figure to hand. I can certainly find it out for you. So we do take discharges from A&E as well, ED. We tend to see more of their patients out of hours. So obviously the ward discharges tend to ease off, don't they? And we'll take that. We also take from as deck areas as well. So ambulatory care, surgical assessment area, places like that. We are actually doing a bit of work next with A&E to try and encourage them to use us a little bit more. I would say if we're taking 35, 40 patients a day, I would say probably between 5 and 8.
So 5 and 8
are probably A&E ED patients.
That's lovely, thank you. If you are able to find out that percentage, that'd be really helpful to me.
Yeah,
fabulous.
No problem.
Thank you so much.
No problem.
Thanks, Pam. So Lucy, going to go back to Lucy for questions in the chat.
So loads of questions. I think quite a few of them have been answered just by the questions that have been asked verbally and additional information that you've given. So I'm going to combine a couple of questions into one, which I think sort of would probably summarise the last remaining questions. And that is, how do you communicate your weekend opening hours and your criteria to ward staff?
So when we extended our hours, we went to comms. Obviously, it goes out on our daily dose that goes out that all staff can access. So I don't know if you've seen in one of the slides, I've got a big fold up banner thing and it's on there. And as well, it is just reinforcing when we changed our opening hours, ringing these wards, letting them know that you are open and what times you're open till. Because it was weekends. When did we start the longer weekends? Was it like January time? Yeah. So we went from 7 till in the week over the winter period, as in like up until about Christmas. But January time was when the weekends went 8 till 8. So it is literally just getting around, speaking to staff, reminding them that we are open and what time we are open till, and the fact that we don't use the terminology that there's a cut-off, because there's no cut-off as such. It's reviewed on a daily basis. You know, if your ambulances are running well and patients are being picked up promptly, then we can have patients sort of like till the bitter end sort of time that we're closed till. But it's assessed daily, isn't it?
Yeah. And from our point of view, obviously, like I've said before, the close working between the operations site team and discharge lounge. So as part of the site team are out on the wards throughout the day, collaborating, definite discharges, potential discharges, and they're also sharing that message. To be perfectly honest, it is sort of rammed down the ward staff's throats at times. It's just continually pushed onto them. So there is no way that they won't know, if you get what I mean.
Thank you so much. And I think what I'm hearing, I think probably a theme from your presentation is being proactive and reinforcing the message.
100%,
definitely.
And that's just not myself, that's my team, because they're all so passionate about it now. I also as well, nurses, CSWs, the ward clocks are going up, aren't they? So they went up to the operations team and sort of say the importance, you know, get them behind you, the importance of the discharge lounge, so they can see the ambulance waits, they can see this, and you know what work they do and what work we do. So it was sort of like merging the two, so you can appreciate each other's workload, and then your staff fetching the patients then understand it, so they get the little skates on a bit quicker.
Yeah.
Put it bluntly, because they understand the process of why.
Brilliant. Thank you so much. Back to you,
Let's
Nick.
go to Teresa in the you've got a hand up.
Thank you. I'm just putting on my camera. I've been on no camera for now, and I apologise for behind me because I'm doing this from home. Yeah, my name's Teresa Pugh. I'm the nurse manager at Wirral University Teaching Hospital Discharge Hospitality Centre, as we call ours.
That's nice. I like that.
Patient Transport Service Manager. You say you get 35 to 40 patients out per day. And I wish we had the same members of staff that you have in yours. Just to pick up on the lady's question that I had before of the percentages of patients that go out from your total discharges. We get between 50 and 55 patients out a day through our discharge centre, which becomes roughly about 60% of our discharges from the trust. Just a question I wanted to ask you about your weekend discharges. Do they tail off during the weekend? Do you get less discharges of a weekend than what you do Monday to Friday?
No, definitely from the wards.
Yes.
And I would imagine this is everywhere. We definitely don't get as many discharges from the wards as we do of weekends as we do in the week. The trust have done a lot of work around trying to support 7-day working, really. We've definitely introduced more ward rounds of a weekend now than we ever used to have. And that has seen some uptake in discharges, but it's still not a comparison to what you get in the week. So what we tend to do in the weekend is we focus on the areas like we've just said. So our frailty areas, our ambulatory areas, our A&E, and just try and release any pressures there. So we do find we get quite a few frailty patients come through over weekend. Obviously, they've only got limited space, so we definitely pull from those out of hours a little bit more than we probably do in hours. And I say same with the same-day emergency care units. So we do shift the focus of where we pull from, but we are still getting not the same number. I absolutely agree, but I would still say about 20.
Yeah,
about 20, 25 going through over weekend, which to be fair is a lot better than where we were on discharge wise 12, 18 months ago. So a work in progress.
Sorry, did you say you're open till 10 o'clock of a weekend as well?
8 o'clock, 8 to 8 of a weekend.
Okay, lovely. Oh, thanks so much.
Cheers.
Thanks very much.
Cheers, Teresa. Thanks,
Thank you.
Quick,
Thank you.
So conscious of time, I'm going to quickly throw to Amy, and then Lucy's going to wrap up with a couple of minutes at the end. So, Amy, over to you.
Thanks so much. I'm Amy Oxley. I'm Deputy Chief Nurse at South Tees, Middlesbrough. Really enjoyed hearing about your service, so thanks for sharing. Learned loads from you. Just a question around same-sex accommodation for your area where you have beds. How have you managed that?
So, with regard to the bedded areas, we sort of see what's, I don't want to say, we sort of see what's coming through So because we've got the package of care list the night before, and we've rung and know who's coming for when we open at 7 o'clock, we can sort of see what's going in there. It is
we do keep it as single sex, the bedded areas, it is single sex.
It is on our risk register just in case, because if there are A&E patients that are coming down, obviously it's better and safer for them to be in our department than in an A&E department. And if there is the case that obviously I've got ladies in there and the man is on a trolley, obviously we do filter that, but that's why it's on our risk register. But my main thing is that we try and get these patients as decent as we can, as in clothing, obviously make sure they're covered, just to obviously to eliminate anything like that.
Like Rach said earlier, we have got the side room as well, so we can sort of flex up and down a little bit with that. We have, if we needed to, we could absolutely empty one of the seated areas, because there's 2 seated areas. We could empty a seated area and create that into a bedded space if we needed to. But I think since we've been down here, we've probably only ever had to do that once.
Okay, thanks so much. Thank you.
Thank you.
Thanks, guys. So we'll wrap up any questions. I think Lucy's going to collate those, so we'll get those over to you, Rachel, Nikki.
Yeah.
And if there's any other questions, we can maybe just answer those simply, and we can share those with the team. Just before I close down, hand over to Lucy for a moment, just share some information that we've developed in terms of background around discharge lounges. Lucy.
Thank you. I just want to quickly share my screen. Can you see that?
Yep.
It's coming through now. Yeah.
I can't see any of you or the chat box anymore. So my name is Lucy Barnett, and I'm an improvement manager with ECIST, and a nurse by background. I just wanted to talk to you quickly about the Discharge Lounge best practice principles document that we've developed in collaboration with the NHS England London Region Discharge Improvement Programme team. So just to bring it to your attention, which hopefully will be of interest to some of you on the call today, although slightly dry in comparison to what we've just heard from Nicky and Rachel. So this is the document. Just to give you a brief kind of introduction as to the origin of it. It came from a system asked London Region around guidance on best practice for discharge lounges. And we agreed, ECIST agreed to do this piece of work in collaboration with the London Region. And so first of all, we took a look at what the evidence said, and we found that actually there is evidence that discharge lounges have a positive impact on patient flow and quality of care. And specifically the 3 areas that popped up in the evidence were allowing beds to be freed up sooner in the day, reducing turnaround time for their discharge, and a positive impact on patient experience and outcomes. However, what's also really clear is that the evidence available is piecemeal, and there's no comprehensive best practice evidence out there. So the aim of this document is to provide some consistent guidance in relation to emerging evidence, recognising that it is limited and piecemeal on discharge best practice principles. That said, it's not a prescriptive model on what a discharge lounge should look like. It's not an implementation guide. It's a set of principles and the characteristics of a well-functioning discharge lounge. So it's based on literary evidence, but also from actually conversations we have with our systems up and down the country that we're working with, including places like Walsall that are obviously doing some really amazing work. So what we've come up with, what we found, are 7 principles of a well-functioning discharge lounge, and I think these probably echo a lot of what Nicky and Rachel have already talked to us about. But they should be a safe and comfortable environment for patients, and that's about easy access, accessible facilities, food and drink, etc. A service to bridge the gap between the acute admission and return to the community. And so that can include thinking about your hours of operation to meet demand, the pull model that Rachel's been speaking about, and taking patients from ED, well socialised with key stakeholders and easily accessible to ensure maximum use. And certainly in the literature, the biggest barrier to the use of discharge lounges is actually lack of buy-in from ward staff, clinical staff. So that's a really important one. And we've heard a lot about opportunities to actually engage with staff, but this can include well socialised access criteria and opportunities to engage with ward staff and myth busting. Use for all patients with facility and staff in place to meet patient need. Able to carry out discharge activities. including receiving prescription medication and completing discharge paperwork. Also had some really good examples about that today. Part of a holistic system to support patient flow. Really important, these aren't considered standalone facilities, but part of a full journey of patient flow, and able to access short notice transfer options, which we've also talked a lot about today. And just to sort of conclude, discharge lounges shouldn't be a waiting area, just used for a specific patient group or evaluated as a separate entity. So what we've got the 7 principles, and then underneath each principle there's a set of enablers with a little bit more detail. We've tried to make this really simple and concise and easily accessible, busy staff. So it's in a format of a checklist, so hopefully useful to members of staff. So just, excuse me, just at the end of the document there's some contact details. So we'll obviously circulate this after this session, but if you've got any feedback on this document, or there's anything else you'd like to see from us in relation to discharge lounges, whether it's resources or whether it's sort of learning sessions and networking, then please do get in contact, and we look forward to hearing from you. Thanks.
Thanks, Lucy. So I guess we are at just the time now, so I'm going to wrap things up. Just a huge thank you to Nicky and Rachel for doing this today. I know you're mega busy, and I think it's just a brilliant presentation. So thank you for that. I think it's been really helpful for everybody. I'm so proud of how you've shared that with everybody today. So well done for that. As I said before, I'll tidy up the recording, get that shared around with everybody, so you can share it with colleagues who maybe haven't been able to join us today. As Lucy said, any questions, any queries, please ping it our way. We'll try and respond to those. And any questions we haven't picked up in the chat today, we'll respond to. But for now, have a pleasant rest of the afternoon, and we'll see you all soon.
Thank you.
Thank you very much. Thank you.
Thanks very much. Bye.
See ya. Bye-bye.
Rachel, Nicky, do you want to hang on?
Yeah, I will do.